So we have a 60-year-old lady who had symptoms of shortness of breath and exertion, has had 4 admissions with heart failure in the last 6 months. She's currently in NVHA class 3. She had an MVR for rheumatic MS with 27 millimeter Biocore in 2013. Clinical examination revealed signs of severe mitral regurgitation. She was referred from our peripheral center from a surgeon to the heart team at India Valves. Next page. These are her investigations. She has rate control atrial fibrillation. Echocardiogram in the form of TOE confirmed severe valvular MR due to bioprosthetic leaflet dysfunction with good LV systolic function. Her lung function was normal, carotid Doppler was normal, and gated cardiac CT showed unobstructed coronaries. Next slide. So this is her STS risk score with a mortality and morbidity combined of 27 with a mortality of 4.1. To add to other indices which are not an STS, she weighs 45 kilograms. Next slide. She declared she does not want any open heart surgery, even though she was offered open heart in the first instance. So therefore the options are transcatheter valve with a transapical valve-in-valve or a transvenous transseptal valve-in-valve. So to plan these, we did some analysis on CT. Her Biocore 27 has an internal valve diameter of 22 maximum. So we decided to go with a 26 balloon expandable TAVI valve from Innovari, Braille Innovari. Unfortunately, patient can't afford an Edwards system, and therefore that would have been ideal because it has a pusher catheter, but that was not possible for this lady. The iotomitral angles, as you can see, although looks nearly 90 degree, there is enough room even after the valve to prevent an LVOT obstruction. She is very frail, therefore one of the plans that we have come up is a transjugular transseptal valve implantation, and if that fails, plan B would be a transfemoral transseptal, and if that fails, then we go for a right atrial TMVI or a transapical. Because of a body mass index, we are trying not to do any surgical procedure, but if we have to, then we'll get to that stage. So let's come back to the lab. So we have here Dr. Sanjeev Agarwal, Chief Cardiologist at Fortis. We have Dr. Prashant Vaidjanath, Senior Cardiac Surgeon, and we have anesthetist, Dr. Suresh Rao, and he's the chief anesthetist at Fortis, and we have the rest of the teams here. So let's go through what we have done so far. Can we go to TOE just to get a feel for the images?
Sheet open. Open the sheet.
Can you see the TOE?
Yeah, open it.
Okay, before we go to the TOE, let's show what we did in the stored fluoro. Let's go to the beginning. Are you all able to see the fluoro and hemodynamic screen?
Yeah, it is very well visible.
Okay, thank you. So what we've done is through a right subclavian approach, we have put a long sheath and a pacing wire. Then we have also obtained a right internal jugular access. Then from a right femoral venous system with a BRK and SRO, a transseptal was done Next. So you can see there transeptal access was achieved with contrast in LA. Once that was done, a wire was passed through and through through the valve. In fact, 2 wires were passed through and through, and both wires were snared out through the aorta. The one of the wires was exchanged for a super stiff system, which means we have a veno-arterial VA loop in the femoral vessel. Through the other VA loop already created, we passed a JR4 retrograde through the femoral artery arch and back through the septal puncture into RA. Let's get to that.
pusher आ जाएगा ये
So this is just snaring in the arterial system.
इतना रहेगा ना हाँ ये 15 सेंटीमीटर है ना
So here you can see the wire snared in the venous system
it will go through the
and taken up into the
reach the mitral
right internal jugular
ये बढ़ जाएगा
vein. So therefore we have 2 VA loops, 1 VA loop
Like a
through
pediatric
the
patient.
jugular into the femoral artery, and another VA
Pediatric
loop
patient,
from the femoral venous vein into femoral artery. Through the femoral venous vein and femoral artery loop, we have taken a 14 balloon and dilated the septum, and that's where we are now. You can see I've left the balloon up so that we have a septum which is well dilated that will allow the valve through from the jugular approach. That's where we are.
yeah
So we're going to get on with the valve prep. While if you have any questions, you can ask Dr. Sanjeev is here, Dr. Prashant is here. They can answer any questions while we prepare the valve.
here sterile scale give it
3-way tap.
Could you open a cook sheet also? No, let me measure it with the scale. Here a sterile scale.
So, Gopal, where are you right now? You have done all these things.
So we've done all this. Now we're just getting the valve loaded.
Okay.
Unfortunately, we were running slightly late
problem,
because of the various
Take your time.
exchanges and everything.
Yeah.
If you have any questions, perhaps you can answer them on our behalf.
In basic,
You
so
know a
what was the
scale?
size of the biocore? This was a biocore valve?
It was 20.
This is a 27 biocar.
27 biocore.
50-50.
Okay.
Diameter is said
So,
to be
did,
22.
because there is now an app which is available on the mitral also, which was developed by Dr. Bapat. And this valve actually gives all the pictures and also gives sizes. What kind size of the transcatheter valve you have to choose in this particular case. But many times we don't have the exact records. So then we have to do what he did, is to do a CT scan and do the exact measurements. But the exact measurements are different because there is an inner felt
Make sure 50-50
inside this
ma, very
ring,
careful.
which is which is the surgical valve. So that is why it is different. So it is better to refer to the app which is available.
So this would probably tell you to use 1:1 or 0.9 kind of.
For every valve it is different. I'll just show it to you. This is valve and valve aortic, and we have valve and valve mitral also. This is the valve and valve mitral. And this shows all the pictures. So as he said, biocore 27. So we go to the valves and biocore.
Is it
and
going?
on this you
Lengthen?
can select the size.
No, scale I'm
Okay.
scale.
So the sizes, and this is how it looks on the image.
Hold this.
So you will see just a ring and nothing else. It's basically doesn't have the body or the struts, and then it tells us if it is a 27, then the true ID is 22.5, and the height is 17,
Yeah,
and the sapien
should
size
go.
required for this is 26. So it clearly, gives all the information, and then of course you can start deployment. It also has pictures which you can compare with yours. So in sapien,
Since there is evidence of atrial fibrillation, so are there requirements for any special precautions for this atrial fibrillation?
yeah, the main precaution is that the
think it should
patient
just
must not be
reach
having a thrombus in the left atrial appendage or the LA at the time of the procedure. Otherwise, you cannot do the procedure because you are entering into the left atrium. And especially, at least we have done with the sapien valves, the Edwards S3, and it is very easy to go from the transvenous transseptal approach, and dilating with a 12 millimeter balloon is quite enough for the septum.
Crimp it, I'll wash it.
Yeah, so the advantage is, no, the thrombus precaution is there. You cannot have a case with thrombus inside. So if there is a thrombus, anticoagulate, bring the patient back in 6 weeks or 3 months. If there is no thrombus, then go ahead.
So Praveen, why do you need two hair loops on this case? I mean, is this just an abundant precaution? Or?
So probably because of that, because he is doing it in a different way. And generally with the Edwards, what we do is, it is rather simple, that you do, as we do the balloon valvuloplasty, but in here the puncture is posterior and inferior. So that as soon as we puncture, we start looking at the mitral valve, and it is very easy to cross the mitral valve just with the pigtail. So through the sheath, we enter with the pigtail, and on the pigtail you can put the heavy duty wire. Compared to the? Yeah, in here what is, because the device is bulky, so you need a pathway which is much straighter, and you don't want to, because the valve can get embolized, because the valve is mounted on a balloon. So that is why you need a clean passage for the entire system to reach the mitral valve. This is T guided. This is T guided puncture. So that is why the use of T is important in this kind of situation.
Can there be requirement of the jugular venous approach while doing the this implantation? Is there any specific requirement for that?
No, for the sapien implantation, there is no need to go from the jugular side. You can, if the passage from the transfemoral side is clean, there is no problem in the IVC, then you can straight away go from the femoral vein, go into the RA, LA, and into the LV. But as you know, as he was discussing, one of the very important factors is the LV outflow obstruction, and that is what we have to do. So those are the precautions we have to take when we are doing mitral
If we
valve.
can show you the valve
Yeah, please show.
for a second.
And also explain, Gopi, about where this valve comes from and what is the sizes which are available.
Yes.
Okay.
Sure. So the size, this is a balloon expandable cobalt chromium platform where the leaflets are sewn in. It's very similar to the Edwards. It's been out there for over 8 years with a 5-year data now. And it comes in various sizes. It also has a 20, 22, 24, 26, 28, and 30. The length of this stent is about 20 millimeters. And we are going to crimp it this way so that the flow has to be from here towards the bare end. That's very important when we crimp it, because we're now doing a transeptal approach. So it's completely a different way of crimping.
So you are going from the jugular approach, you are introducing the valve from the jugular side?
From the jugular approach, hoping we'll get a straight trajectory,
Okay.
as opposed to coming from the IVC.
And what is what is the profile of this device which is going inside?
The profile of the device is in a outer diameter of 24, so we need an inner diameter sheath of 24, i.e. an outer diameter sheath of 26 plus.
That's quite big actually, compared to the
Yes,
the sapien, which is just 14 and 16. It's 14 for the smaller size of the valves and 16 for the bigger size of the valves.
Yeah, this will be the inflow for mitral valve.
For the sapien?
Stop.
Femoral, because
Is it-
for the
is it,
14
high
or
enough?
16 it is almost like doing a balloon
Just
valvuloplasty.
maybe just.
So it is not a big
What about your sheet?
profile as
Let's check.
this is. This is 24.
See,
almost
we
double.
can make the valve incompetent.
Can
and
you
put
show
this
the shaft also?
your sheet.
The shaft, catheter shaft?
This kind
They
of
want to
diameter
see this
per
thing.
we
This
can
is a bovine pericardial valve.
venous access, right? I mean, this.
Or transapical?
That is-
The important thing is that this is the same valve which is used for the aortic implant.
So, 1 minute.
But in here what we are doing is that we are reversing the valve so that it doesn't, the flow doesn't get obstructed. Otherwise, the patient will die immediately on the table.
Transapical, is there any risk to the cordy? I mean, chances of damaging the cordy. How do you take care? Again,
So just
through
check this side.
transesophageal
So we are
guidance.
going to do from here.
Yeah,
Doing transapical is
Yeah.
not a big problem. Actually, it is quite
Yeah.
easy to do.
perfect.
But certainly, and this cordy thing is not a problem because it's all guided through the transesophageal. So,
we're just
before,
crimping
you
now,
know,
just bear with us.
How many this kind of implants, valve in mitral position, are done in the country so far? I believe you did the first one, and
yeah, we did, and then we followed it up with some other cases using the same Sapien 3 because that's the only valve which is available in India, although it is a off-label indication of using the Sapien valve in the mitral position, and all these cases were the mitral valve in valve. And of course, one of these patients was very, very sick, like almost on ventilator and very sick patient. But the result you get is quite phenomenal. Immediately, the gradients are gone, there is no leak, nothing. And the only risk is that sometimes there is a LVOT obstruction. So that is something which we have to consider.
so that you can decide based on CT that the valve will not protrude
Yes,
into
yes.
the LVOT.
Absolutely. CT is the most important investigation before you take a valve in valve. Number one, to assess the size of the valve, because sometimes the report may be wrong, because that happened in one of our cases. The patient was treated in, I think, 1998 or 99. We got a report saying that a particular tissue valve has been implanted. But when we checked at the image, we saw that it is not the same valve. So, because now we can make out from the app and also from the pictures which valve is which. So it is very important to reconfirm. And we found out that the valve which was written on the discharge summary was wrong. Maybe in the OT they couldn't find that size, although the resident wrote some other valve. So anyway, so it's very easy to find. And based on that, you have to decide which size of the valve you have to use for the valve and valve.
So the CT can tell you what valve has been put 10 years
And
back?
also the fluoro images. The CT and the fluoro, both you have to do. And CT tells this thing. The second thing which it tells is the LVOT angle and the distance and the aortomitral continuity. All these things we assess. And many times, as you were saying about the LA appendage, the surgeons have actually cut off the LA appendage. So there is not a big problem in these patients, because these are post-MVR patients.
The obstruction you are to assess through the TE or through the, during the
So during the procedure, we have to assess with the TE. The TE, yeah. So transesophageal echo is a very important adjunct while we are doing these cases. And the procedure generally takes about 35-40 minutes.
Height selection important.
Let it come back.
Height of the prosthesis.
The height of the prosthesis will remain the same because the valve is the same. So it is the same valve. And generally, some valves are coming which are known as stentless valves,
Flush it.
and some are stented valves. The
Get a 50
already implanted surgical valves, as you will see in the pictures. Here you see that this valve does not have a radio-opaque stent on this.
ACT.
And also, important issues are that the length of the leaflet of these valves sometimes can lead to problems. So those are the things which we know by the make of the valve, and that's how we have to decide what will be the positioning of our valve so that it doesn't go too much in the LA or the LV. He is using a Innovari valve, which is a Brazilian company, but we are using all the time Sapien S3. Yes, yes, yes. So that is why it is easy, and you make a dilatation of the septum, which is about. You can even do it with 10. We generally do it with 12.
Yeah, knife.
And then close the septum. If the RV dysfunction is there, then we have to close the septal defect with any of these devices.
Knife.
So this one
11
we
knife.
used a 14 balloon to dilate the septum.
Yeah, here they used a bigger balloon, 14. So in this case, definitely they have to close the defect after the procedure is finished.
Can you press this? Can you press this?
Here it is 24, but in Sapien it is 16 or maybe at the most 18. Because Sapien actually comes with a E-sheath, which is 14 or 16 already. But sometimes if you want to use another sheet, you can use that, but this is good enough.
Sapien you can't use in valving valve.
That is what we do. We do the Sapien valve, and here also we do the same thing. We reverse the valve while it is being mounted on the catheter. So what's the situation? Is everything okay?
So, yes, the valve is all crimped. Perhaps, Dr. Sanjeev, you can show the
You can show it, yeah.
valve. Yes. So while we're just getting the sheath system in, apologies, we're running slightly late than planned.
Yeah, it's already, I don't know up till what time we have we have till 5:30. So you have 21 minutes more
That's what I'm told.
from the satellite.
Okay, that's...
We started a
That's
little
very
late, so
generous.
maybe the satellite is a little more time is available. How much is the satellite time available?
I hope so.
Okay.
Okay,
5:25,
It's T.
5:35. Okay.
X-ray.
So don't worry, take your time,
T-
don't be in a
X-ray.
rush. We have 30
X-ray,
minutes to
okay.
go.
Can you change this
Can
thing?
we get the pedals here, please?
That's right.
No, not too much. Camera. Okay.
Also, there is a risk of the valve going embolizing
can
into
see
the
the
LV,
T.
because there is a
So I
patient
don't
which
know
was
if you
being
can
done
see
somewhere with the same
fluoro.
Innovari valve, and the valve embolized into the left ventricle, and the patient had to be shifted to surgery. So that is another risk, because it is a very small window which is there where you have to implant this valve.
You mean if you are too deep towards the
Yeah,
LV,
yeah. It
the
can just
valve
miss.
will slip, yeah.
You can miss.
Let me just... You can take it now.
The valve has to
I'll
catch
just
the
release the,
waste of the
wire.
Yes,
original-
yes, exactly.
Still
It has
there?
to
Wire.
position properly. Otherwise, it can just go deep in and then embolize, because there is no support.
Screen, sir. Screen there. Press screen.
So you are accessing from the jugular side,
That's correct.
and which wire is this on which you are going?
So we're going on a super stiff wire,
Hmm.
which is exchange length. Come RAO, please.
And you are trying to railroad it, yeah?
Yeah.
Since both the axes are available, one towards jugular and one towards femoral, does
more,
one is better than the other one as far as support for the valve comes? Not really.
No, they are trying to do the jugular because that will be a straighter trajectory.
That's what I'm saying.
Quick
So
one,
jugular will
yeah.
be better, easier than the femoral.
For this high volume device. Yeah. So here you can see that the ring of the valve is what you see. Although many times you see the entire structure of the previously deployed valve, but here you just see the ring, the wire-like thing. That is the valve.
me, sir. Not too tight, just.
No.
So he is trying to cross through the septum, atrial septum.
Through into the valve, inside the valve.
He will have some resistance.
No,
It is
it's okay.
crossed very well, but again coming back.
Okay. Hemostasis, sir.
Yeah.
So that was just the dilator that you
Okay,
saw.
okay, okay. So this dilator was, how big was it? The same?
This was a 2022 OD.
Okay.
So on TOE, I want to know whether the sheath is coming through. Huh?
No, you go to the mitral valve straight away. The sheath. Yeah.
Yeah. Yeah, steps are short. Okay, okay. So I got it. So you are asking. Oh, yeah.
The problem is severe MR, isn't it?
Yes.
Not
yes.
too much
Suppose
tension, sir.
restenosis.
Yeah. No problem.
No.
If the valve is degenerated valve
Oh.
and doesn't have too much of thrombus there,
No.
then in these cases, whether it is mixed MSMR or severe MR or severe MS, you can use it
You have
in
one-way
all the
valve.
three
1 second,
conditions.
sir. 1 second, sir.
Because in one of the cases, we had severe mitral stenosis and the patient was not responding to anything, so that is
Step, sir.
where we did it. And in fact, in one patient, we did a balloon dilatation first
Your sheath is
to
inside
stabilize the patient, and the patient has stabilized so much that we have given up the idea of putting another valve. We'll wait for the
Yes,
more
yes,
deterioration
yes.
and then only
Coming.
we'll do the implantation. Because the gradients are good, no MR, so he's doing fine.
Okay, just hold it, sir.
Even if it is a degenerated valve, there will be some amount of flesh and tissue will be there, Will it not hamper the opening and closing of
It
the...
can. It can. In this patient, as I said, that it all depends upon how much of this is degeneration and how much of this is the stickiness of the valve because of thrombus. So in those patients where there was some thrombus and the patient is not responding to regular thrombolytic
I'm gonna
or
release the
anticoagulant therapy,
And as I release,
you can
see
do
if
a
you can pull the
the
wire
balloon
and push
dilatation
it.
and then
Yeah.
see. But there is a risk
Slowly.
of embolization at that time.
Okay, ready?
Yeah.
I'm coming down. See if you can push it there.
Yeah.
Release this one, sir.
Yeah. It's inside the septum. It's inside the.
Dilator is inside the septum.
That's a straighter path.
Yeah, it's coming. Coming.
But the only good thing is that they have a complete end-to-end loop. So
You have enough wire down.
That's fine, sir. That's okay.
You have enough wire down, no? Okay.
Okay, hold this, sir. Don't let go.
About 2 centimeter, but yeah, 2.
Hold this.
yeah, so this gives us an idea as to how the actual valve will go inside, and they are trying to just do the dilatation. However, the dilatation at the septum is not required because it is already dilated. Yeah, so they're trying to help this sheath to go inside. So the sheath is attempting to take the sheath inside.
Dr. Praveen, is this the valve? This one?
No. This is the wire on which there is a dilator and the sheath. So now you see the end of the sheath.
Hold this, sir. This.
The wire is the valve. Yeah, this is the old valve, the first valve.
Yeah, that's what I'm asking.
Yeah, this is the valve.
Tension.
No.
So this is a BioCore valve, which you can see on, if you can, you can download it later. It's a VIV mitral app which is available.
should be in.
Struggle. Better to take
In
the valve.
RAOUs, you are
Maybe
not
dilating
seeing it
it
end on. That's why you are getting confused. If you see it in LAOU, it will open up totally. In RAOU, it separates from atria to ventricle. It forms
That's
like
open, but the sheath
seat
is
there.
pending. So what we'll do is we'll take it
Can
into
you
the valve.
explain the course of that sheath? Where is it taking the U-bend? Is the U-bend in the LV or in the
Septum.
RA? Where is it taking the U-bend, or in the RA to LA?
No, the sheath is coming from the internal jugular vein into the right atrium, and then it will go into the left atrium, and
Valve.
of course through this they will take the valve inside.
The end of the sheath is in the left atrium,
The end of the sheath is in the left atrium at this time.
and the dilator.
They are trying to enter actually. It is somehow not getting into the left atrium.
Put a cover there.
It's
No,
getting stuck at the
Take it
septum.
close in.
Yeah.
So there's a little bit of resistance at the septum.
Yeah.
Whether they went through the septum last time, but having dilated with 15, I'm hoping there's enough hole there. So therefore, I'm just going to take the valve with the hope that we can back it with the sheath. Because that is the only option now.
So you are
Because
taking the valve
otherwise,
now?
We'll be taking. Yes, we're just going to take the valve next, very shortly.
Because then the valve may hit at the septum.
Well, I'm hoping we're going to use the sheath as the pusher. So this one. This one. Make sure this one is. You don't bend it, sir. We can't.
Will switching to groin help in this case? Switching to groin?
Maybe, yes, absolutely. That's an option. I'm going to push hard. Sir.
Yeah.
Yeah.
Yeah, that's enough. No? That's enough.
Clamp. Take a clamp.
Clamp. Very big clamp. Just a big one.
Dr. Praveen, if you don't mind, with the pointer, can you
Big
show us
one.
the course of the,
Yeah, so
course
this
and
is
where
the
it-
sheath.
Okay.
This is the sheath,
Okay.
and inside the sheath there is a wire
Okay.
which is going from the internal jugular vein into the right atrium, through the septum, into the left atrium, and then from left atrium into the left ventricle and into the aorta. So that is why they are trying to track it. Normally what we do is, when we are doing from the Edwards side, with the Edwards valve, we go from the same way from the femoral vein, IVC, right atrium, left atrium, and then into the ventricles.
Okay.
There is no looping of the wire into the atrium, into the aorta.
Okay.
Because then what happens is that the wire comes like this and then makes a loop inside the ventricle.
Okay.
In here what he is doing is, he has taken the wire, going into the aorta and coming into the descending aorta through the femoral artery.
Okay.
So that he has more support for this very heavy
Okay, fine.
size of the this valve.
So are you trying to say Edwards would not need this much support, and that's why just looping in the LV is good enough?
It's quite good.
So
Actually, it comes straight into the this. Yeah, it is only 14-16, and that too, it's not a big problem.
The tip of the sheath is in the LA, but away from the mitral orifice. And that is the reason they are not able to take the valve in.
Yeah.
Now, can we negotiate the sheath to face the mitral orifice through some other catheter?
Yeah, so
or something?
normally what we want to do is that we have the sheath which should go from here and see the mitral valve, be somewhere here, and the sheath comes like this, see here, through this we enter into the ventricle, because this is the mitral valve.
Yes.
And
Don't have a
on this there is a heavy duty wire, the super stiff wire, which goes down there, makes a loop and stays there. And on this you can easily take the valve inside.
But the trajectory from the jugular should be more ideal
More
than
straight.
from the
That is,
IVC.
yeah, so that is why he took this. But what he has done is that he has taken a loop into the aorta so that his valve doesn't get lost.
That is leaking.
leaking.
Sir, I
So-
think
I'm Dr. Santosh from.
So his valve has to come somewhere here, and his sheath end is here.
So Dr.
Okay?
Praveen, one small, I'm here. So I think there is a problem here because from the mitral annulus you can see there, next to that is aortic annulus, and if he makes a loop inside the ventricle, I think it will become coaxial and the sheath will go directly.
Absolutely.
I think you should advise him to do that.
Yeah, in fact, because since I have never tried this kind of approach, so I don't want to give him any suggestions to him at this time. But certainly, what we do is we put the wire into the, loop it into the left ventricle.
I think it should have a V-shaped thing happening in the LV apex.
So what you are saying is exactly what we do from this side, you do it from here. You put the wire from the jugular vein into the right atrium, left atrium, and going into the left ventricle.
Yeah.
So that may track the whole thing.
That that acute bend can be avoided and it becomes coaxial to the LV apex.
Put one sheet here.
No,
Maybe,
but
yeah.
Praveen, I would have reservations the way you're saying, because this is obviously giving a stronger support
It's a
for
very
the.
strong support. That's why.
I mean, there is no question that
But the
this
problem is
VA loop is giving a stronger
but the
support.
problem is that this sheath is very heavy, big, voluminous sheath. That's why it is not tracking even this thing. So you see, as soon as it's pushing, it's going down. Yeah, it's getting bent now. You see, the sheath is now getting bent over here.
See, Praveen, but I think most of us are good mitral operators through the femoral route. Even though the jugular procedure for the BMB existed long back and there were very few operators who opted for that, but more than 95% of the people always did the BMV through the femoral route. So probably we may be better at doing it transfemorally rather than going the jugular route. Whatever may be the diameter of that or weight of the valve, the rigidity of the sheath.
Get one sheet.
The only advantage right now with him is that he has an entire loop with him, so that nothing will get.
We are not denying what he is doing.
Yeah.
That is not the issue.
One more dilatation.
What I will suggest is that he should maybe cross the sheath with the help of dilator, because otherwise it is getting bent and not getting enough strength to go through.
If he pushes it from the femoral into from the opposite side, so that there is more of wire inside the left ventricle, the whole thing becomes coaxial and it should go inside easier.
Okay, hold this. I'm going to push a lot,
Yeah.
Yeah. Now he's bringing the valve. You see that the valve has come inside the sheath.
The theory out.
Can you pull the T probe a little back? Because
Theory slightly out, please.
yeah, pull T probe back. Yeah. More. Yes. Okay. So now it is at the septum. You see the valve is at the septum, and
Pull.
sheath is back.
Keep tension.
This is a very crucial moment for him. Almost there. Yeah. Well, was getting partly across that. Some bradycardia.
We're losing wire. What's the pressure happening?
Pressure.
Pressure is okay.
Pacing wire will be required at the time of implantation. Yeah, it is. The pacing wire has moved,
Just hold it.
so they will have to reposition it if
Fix the
it
pacing
is not pacing, because then this will be very much very important at the time of implantation. Because if you start implanting while the heart is contracting, it will jump inside.
And you position this valve 50.
This is a very, very crucial thing with all balloon expandable valve implantations, whether it is even aortic or aortic also. This is the most crucial step.
You position this what 50-50, half in the LA, half in the LV.
Balloon up.
It is basically, again, we have a guide to that. For different valves, it is different.
Where is the valve? TOE?
It's not yet entered.
No, it is not inside.
Because it all depends upon shortening of the valve.
Has it crossed the septum, sir?
Normally the valve, which is the Edwards valve, shortens from here till here. This will not shorten.
From the balloon, sir.
Hmm?
The valve is moved from the balloon.
Hmm.
Slightly there's displacement of the ground.
And almost always we use a balloon tipped pacing lead.
Yeah.
Because
This is
and here you see this is the balloon tipped pacing lead. So that there is no risk of perforation. In the? No.
Show me down.
Down.
Okay, that's okay.
No, it is okay.
Maybe put a artery clip or something like that there. Just getting pulled off.
So when we are putting the lead, this is a very important step. Even if you are doing a TAVI with a balloon expandable valve, the lead positioning and securing of the lead is very important, because many times when we are doing stuff, the lead just jumps out or goes somewhere here there. So once we done the pacing, correct positioning, we seal it everything so that it doesn't move at all. Because at the time of implantation, if there is a pacing loss, it is a disaster.
Don't know.
No, it is looking clear. Try to do.
You're almost getting there.
Okay, just stay there, sir. I'm just going to maneuver it with the balloon from below.
How many?
For me?
Why? No problem.
No, don't
I
let
think
go,
they
sir.
cannot hurry up
Hold this
anything.
one.
Yeah.
And if you have to run off because of transmission, that's okay. But,
Don't worry. Take your time. Finish your procedure.
Achha.
And we will be off. Otherwise, you can show the results maybe tomorrow.
Yeah.
Hmm.
No, he's helping the passage with the help of this balloon. So that along with this it goes inside. It has to come from through the septum and then cross this mitral valve. So it is sitting at the inlet of the mitral valve. He is trying to push with the balloon. The balloon is going very easily, you see. Yeah, through the septum. But it is not able to push this.
Whole wire. Wire matu. Tension. Remember venda. Don't pull too much.
Yes.
Yeah, almost.
Sir, are you inside?
Almost there. Yeah. So
You are inside the mitral valve?
yes, looks like that. Oh, it's helping again. A little bit more.
Sir, are you inside the mitral valve?
Yes.
Prosthetic valve?
Inside the prosthetic mitral. He's trying to push it a little more. No.
Gopi, try from here now.
We're going to pull it from the arterial side.
Yeah,
Yes, yes, yes. It's moved in.
yeah. Sorry, is it inside the valve? Can you?
Yeah, yes, pulled it from the femoral side.
Little bit in. Oh,
Again coming back. Is almost
yeah. Give us
reaching the.
yeah,
Oh,
yeah, yeah. You see in the inside the LE.
it's gone into the left ventricle now. He has to pull it back.
Just give me that.
Yeah, yeah. It's gone past it.
Yeah.
Yes, that's better. So the valve finally crossed. It's gone crossed this. This is the prosthetic mitral ring.
Oh,
Push that wire.
no.
No?
Now we have to get the.
Slightly bit. It's coming onto the LVOT.
Okay, okay, good, good.
Yeah,
good.
so it is.
That's okay.
Yeah.
Okay.
So it is
let's go
different for
coaxial.
different
Let's go
valves.
Coaxial. Coaxial, coaxial.
Yes.
Come. Okay, what's the pressures? No, 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 no.
Pressure
Ario.
No. So
Pressure
we have to
okay.
see the ring straight actually. Then that will be the best.
Okay, that's
way to position this.
another important thing we shouldn't forget.
Yeah.
We have two stiff systems. We have to take
Yeah,
the
you
other
have to
stiff
take it
system,
out.
otherwise we'll
Yeah,
jade
yeah,
it.
yeah. Otherwise they will be embedded inside. Yeah, this wire has to be taken out.